So, everyone's back from the hurricane. Congratulations. You made it through your first Florida hurricane, if you're new to Florida. What was your overall experience? Like, meh, didn't seem so bad. Yeah, nothing happened, right? It was a lot of hurry up and wait. I saw a nice forecast map that had it like hitting Florida around like Thanksgiving and then hitting Georgia around New Year's. A lot of hurry up and wait kind of stuff. But anywho, so hopefully everyone watched the videos that I posted up. Again, I did not check the actual views on YouTube, but I assume it's 63 apiece. I would hope everyone watched those. There's 80. Oh my goodness, some people are double dipping. Even better. Those checks are gonna be coming in soon. I'm just kidding. I don't make any money off of those. Anyway, so slight schedule adjustments. So this time around, we're gonna be able to cover ophthalmology, and so this will be on test 1, FYI. So we'll see what we can cover today and finish, and then the next time we meet, we will finish up ophtho if we have anything there, and then we'll do the test review. So we'll do like a Kahoot review, and we'll kind of go over some questions that are similar to what might be on the test, and then we'll have the test on Monday. Fantastic. I think, are we meeting on Friday? Well, the test is on Monday. I think we're meeting on Friday. So Friday the 13th seems like a fortuitous time to be reviewing for your pharm test. Also, what else to do Friday?
No idea.
Yes, I saw 3 of those in so far, so I hope I have 60 more coming my way. If I see 80 of those turned in, I'm going to be a little curious. Some hidden students up in the ceilings or something. Okay, so any questions on anything we covered? I had 3 or 4 responses about my question in the ENT lecture about Bender the robot and why he was holding a bottle of Robitussin. Some people are like, what? I don't even know what you're referring to. That's okay. Perhaps when you watch that, you will know. That's due to, as people are close, so it had to do with drug abuse and Bender the robot, but they call it robo-tripping. Anyone heard of that term? Probably a little before your time, but basically, again, people will sometimes abuse medications if it's available, and you can go buy gallons of Robitussin. No one's going to bat an eye generally, and so they would take a lot of that, and actually due to one of the mechanisms of the drug, it works as an NMDA receptor antagonist. It actually blocks some glutamate receptors, kind of similar to ketamine. Anyone heard of ketamine before? It's like a veterinary anesthetic. We actually use it for little kids too. We got to set their bones. But it causes kind of out-of-body-like experience. And so Robitussin will do that in really high doses. So they call it robo-tripping. And basically there's kind of different planes of existence you could reach based on certain dosing thresholds. It's not great. I would not recommend it to anyone. I've seen some pretty bad trips coming into the ER. People who thought knew what they were doing. It did not go so well. So robo-tripping is what I was trying to get at with that. No one said so specifically. So you all missed out on the free test question or test answer.
Dang.
I know. No one will ever know that the answer was D, so whatever. Anyway, so any questions on any of the material there? Finish up the antibiotics section, anti-infectives, cover the ENT section. Feels pretty good about that. Let's talk about, anyone feel comfortable moving on? Did you say the ayes have it? Anywho. Okay, so let's get into some ocular pharmacology. So some of the things you're going to see are a little different here in terms of how we're administering these drugs. A lot of them are going to be topical administration. And typically when you think topical, you think of what? You think like creams and ointments and things like that. Typically think about on the skin. This is still topical administration because we're not administering these systemically, right? They're going to be going directly into the eye or on top of the eye, as the case may be. We'll see there's some ways to actually get things into the eye that usually is a little bit more invasive, but less common, right? You know, things like eye drops and eye ointments and things like that we see all the time. Things that are a little bit more invasive are typically more like in the surgical sort of setting. But anywho, we're also going to find, though, that even though you're applying things topically to the eye, you can still see systemic side effects from some of these medications here. Anyone know why? We're going to cover that in just a few seconds. We'll learn why, due to the pharmacology and due to the physiology, how we actually have some systemic effects from these medications here. Now, when you're looking at the actual administration of drugs to the eyes, You see there's a couple different ways to do that. Certainly, most of the drug is going to be administered topically, and usually it's going to be administered sort of the lower part of the eye there. Again, we'll talk about administration into the eye, but basically, you could also have things like subconjunctival injections, retrobulbar, etc. These are usually done by, say, for instance, like an ophthalmologist. We actually had a kid yesterday who's having cataracts removed, and he was getting subconjunctival medications like steroids and antibiotics and things like that. Again, a little bit more invasive, done in the surgical sort of setting here, but we're going to more focus on sort of outpatient topical sort of drug administration. So looking at this, we're going to see the main thing we're going to focus on is mainly going to be topical. So that's the thing I want you to focus most on here. When you're looking at administering this stuff, you're going to find that you typically are getting really high concentrations of drugs to the site of action, which is good, especially, for instance, if you had, say, like an infectious issue going on. High concentrations is good because you can overcome what? Resistance, right? So we really don't have to worry about using a lot of like really kind of more broad spectrum drugs when we're using it on the eye, because most of the things are such high concentrations that can kill pretty much anything we have for the most part. Drug selection is still important in some cases, so things like pseudomonal coverage will still come up, as we'll see. But by applying it to the eye, again, we're getting nice high concentrations, we're getting nice local action. You typically limit a lot of the systemic side effects, which is nice. And we'll see a lot of drugs we've covered previously that they don't have a lot of the same interactions or side effects because, again, we're just applying them topically. However, what are some benefits of using the topical formulations? Well, things like compliance is usually pretty good. Most people can administer themselves eye drops and eye ointments and things like that. However, we'll see there are some downsides to this in just a little bit. But again, this is a nice table to go back to and kind of reference there. What are some things you want to think about whenever you're administering, say, a liquid or some sort of solution into the eye? What are some concerns you would think about that actual dosage form? The technique could be one thing, right? But what about the actual solution itself, the actual liquid? Does like pH matter? Yeah, right. Does tonicity matter? Right, how much stuff is actually in there? It matters quite a bit, and you're going to find that when you're using things in the eye, it needs to be specifically manufactured for the eyes, especially balanced, because otherwise, has anyone ever gotten like seawater in their eye or chlorine water? Does it feel great? No, right? It does not feel great because the tonicity, the pH, all that kind of stuff is off. And so because of that, the eyes are very sensitive to that sort of thing. So that's why, for instance, probably in ENT, or perhaps in ophthalmology, we talked about how potentially you can use ophthalmic medications in the ear, but can you use otic medications in the eye? You cannot do that, right? So you never want to go that other direction. It's just not formulated for that sort of tissue. Anywho, you can see that most drugs tend to be given as solutions or suspension potentially. We're going to find that you can also use things like gels and ointments. And what do you think is the duration of action? How do you think it would differ between like an ointment versus a solution? Which one do you think would be working for longer in the eye? Why an ointment? It's more viscous, it just sticks around for longer, right? And so we're going to talk about contact time, and that's going to have a direct impact on the duration of action of some of these medications here. But certainly when you're looking at more solid dosage forms, getting into gels, ointments, sometimes the actual solid insert can be used in some cases here. And again, more time in the cul-de-sac, right, equals more absorption of that drug that you're going to see there, right? Solutions, suspensions tend to get washed away pretty quickly with tear formation versus ointments and things like that are going to stick around for a little bit longer there, right? And certainly if you want a really long-term sort of drug absorption, you can actually have implants or inserts actually put into the eye itself where you can actually slowly release that drug there. So if you ever have someone who has like cytomegalovirus, retinitis, sometimes that can be used to get really long-acting kind of concentrations of drug into the eye itself to treat that infection that would otherwise be too difficult to manage with just using constant eye drop administration. So looking at absorption, again, the rate and the extent of the absorption is going to be dependent on several things. And this actually goes back to when we talked about absorption across biologic membranes, right? Remember in pharmacodynamics, we talked about Fick's law. Anyone remember that? We talked about things like the thickness of a membrane, the surface area, all those things can have an impact on how well drugs get absorbed. And that can then lead to some systemic toxicities, as we'll see here in a little bit. But more time in the cul-de-sac means you're going to have more contact time, more action on the eye itself, but the more tear production you have, that can then wash away some of that medication. You can also find that nasolacrimal drainage is also going to be another big concern there. Now, if anyone's ever used eye drops before, is there anything they told you about after you apply the drops, what to do with your fingers? Anywhere to apply them to? Yeah, basically you hold the punctum closed there. Why do you do that? All right, so it limits that nasolacrimal drainage. It keeps the drug there for longer. It also limits how much absorption you're going to have. And I'll show you a picture of what that looks like in just a second there. Other things can be important, maybe not so much clinically, but things like drug binding to actual tear or tissue proteins, diffusion across that cornea. Again, that'll talk about, that'll reference Fick's law in just a moment here. And then you're going to find that this can be affected by changing the drug formulation. So you may have something that is available as a solution and as an ointment. You may have varying dosage forms depending on the drug you're dealing with. And again, sometimes we'll actually do things like blocking the tear ducts themselves, either using a silicone plug, or you can actually cauterize that closed and actually prevent drugs from washing away, prevent the tears from washing away. Usually use more for like patients like chronic dry eye and things like that. So if you can imagine here, when you have the nasolacrimal drainage, again, where does it drain into? The nose, right? It's nasolacrimal drainage. And so that, again, is it going to be a highly vascularized mucous membrane? You can see systemic absorption from here, right? So this is why we can, and again, some absorption can happen across the cornea. This is less clinically concerning, but certainly the nasolacrimal drainage is a big thing we're looking at there. And so you can see things like using a beta blocker in the eye can lead to things like bradycardia, right? You can see those kind of systemic effects, and we'll talk about those individually as we get to them a little bit later on. Other things about this, when you're looking at the absorption, it bypasses first pass. Anyone remember what the first pass effect is? So the liver's metabolizing some of that drug before it gets to the systemic circulation. Which route of administration has the most first pass effect? Or, right, so again, you bypass some of that, so you get pretty good absorption there without having to worry about the liver, and then you end up having those systemic side effects as I mentioned there. Now again, depending on the drug, you may find that you can have pretty good transcorneal absorption, but there's going to be some lag time there, meaning it's going to take some time to cross over, and again, that's going to be governed by that Fick's law. If you remember, there are several things that went into that, meaning one, we had the concentration gradient, right? So by increasing the difference in concentration from the outside of the eye to the inside, what does that do to that flux across the membrane? Increases it, right? The bigger the surface area, which you can't really control that so much in the patient, but certainly the thickness of the membrane in terms of the cornea, you think it's fairly thick, fairly thin, compared to like your skin? Fairly thin, right? So you can see some absorption there. As compared to like your stratum corneum, right? You know, it's going to be pretty thick there. Anyway, so these are things that are going to affect the actual absorption across that membrane. Now, looking at the distribution, you can find that after it gets absorbed systemically, the drugs work just like they do by any other route of administration. So distribution is not going to be so much fixed there or changed there. But sometimes drugs can actually accumulate in the eye. Here's an example of a drug called chloroquine, which is an anti-malarial drug, kind of old school, but it actually accumulates in the eye and it forms this bullseye sort of lesion there, right? So again, that would be one thing where the distribution is a little different and maybe it binds to specific proteins or just likes to hang out in the eye for whatever reason there, okay? You're going to find that some drugs, once they get put into the eye, are going to have some degree of metabolism that occurs there. And sometimes we use this for prodrugs, right? Prodrugs are just what? They're inactive initially, and then they have some degree of metabolism that activates them. So as an example, this depiveprin turns into epinephrine. So you guys are familiar with the substance epinephrine, I'm sure. And then, for example, latanoprost is actually a prostaglandin, and the prodrug form gets turned over into PGF2, right? We'll talk about latanoprost a little bit later on in its utility. Anyone know what you use latanoprost for? Glaucoma is a big one. Anyone know what else we use it for? Or the eyelashes. Yeah, we'll talk about prostaglandins and eyelashes a little bit later on there, right? There's some aesthetic purposes we can use it for. And then once it is systemic, it undergoes normal liver or renal elimination, so no big changes there, okay? Really, absorption is going to be the biggest thing. So let's talk about ocular antimicrobials. This will be a little bit of a review because we've covered most of these antibiotics already. There might be a few new ones in here we'll talk about. But we'll find that, you know, the eye is a particular site for a lot of infections. Why do you think that is? Yeah, so you can have things like foreign materials, like contacts that are there that can harbor organisms, right? It's just not as well protected as like your skin would be, right? And keeping organisms out. Not only that, but what frequently touches your eye? Your hands. Is everyone's hands super clean right now? Hopefully, just had lunch, but some people are picking their nose and rub their eye. Or I invariably, anytime I'm ever chopping up jalapenos, guess what I want to do immediately after? It's like an instinctual thing. It's like fight myself from touching my eyeball every time it happens. I'm just like, why every time? Anyway, but these periocular infections are super, super common, especially in family practice, in the urgent care, the ER. You're going to run across this all the time, right? And so again, things like distinguishing between viral versus bacterial illness is really important here, determining the extent of the infection, right? Because again, deciding whether I can use topical products versus more invasive disease, perhaps I need IV antibiotics, right? Sometimes I need to have a little bit higher systemic penetration in order to get more of this tissue covered here, depending on basically how involved that tissue is with the infection there. And so you're going to find that the route of antibiotic we're going to use here can be dependent on the clinical setting. So is there any kind of like penetrating trauma? Potentially got into a car accident and the eye was penetrated. That could lead you to choose more systemic antibiotics. The age of the patient, if they're immunocompromised, just that involvement of the disease, right? So again, once you get post-septal and you start to involve more areas of the eye or the tissue around the eye, that's usually where we're going to require more sort of systemic therapy, either oral or IV antibiotics, as the case may determine. So you're going to find that the bacteria that typically cause infection in the eye will change over time depending on where you're working at. Even things like vaccines can have an effect on what type of infections you see there. So for instance, when the H flu vaccine came out, that did definitely decrease the incidence of infection with that particular organism there. And again, depending on severity, depending on the age of the patient, you may require more systemic antibiotics in order to treat that. Ideally, though, we can use nice local, topical sort of antibiotics, and that's what we're going to focus most on here. Again, we've talked about a lot of those other systemic antibiotics in the previous sections. Okay. Again, benefits of using topically is we limit the systemic bioavailability, which makes sense, right? We only have to worry about stuff coming from the nasolacrimal drainage for the most part. Again, that's not going to be clinically too important for a lot of these antibiotics. You have very high local concentrations, which what does that mean for the bacterial kill? Very good, right? Because you get really high concentrations as opposed to what you would get, say, after like an IV administration. However, because of the nature of the eye and the fact that you're constantly producing tears and you can wash away those antibiotics, you're going to find that you need more frequent dosing. Sometimes you're dosing these things like every 4 hours, right? So you're taking something 6 times a day. That can be pretty tough for patients to keep up with, especially if you imagine, who might be a really difficult patient to give eye drops to? Kids, right? So, and again, kids have really grody hands and they're always touching their eyes. So again, they are a constant or frequent victim of these infections here. And so imagine giving a kid 6 times a day eye drops, right? Not going to be fun, right? So you're going to require a lot of papoosing the patient. You guys familiar with the papoose? What does that mean? Yeah, turn them like a little kid burrito and then force some eye drops in there, and that's no fun, right? You don't want to traumatize these kids here. But anywho, we typically use more broad spectrum antibiotics because resistance isn't so big of a deal here because of the fact that we're getting such high concentrations. It's very hard for the bugs to actually develop a lot of resistance. And then for the most part, you're not going to get a culture for these patients. So for the most part, you're using empiric therapy. You're guessing, okay, well, this is a broad spectrum antibiotic. It's probably going to cover whatever this person has right now, okay? Unless you really think it's an unusual organism, maybe it's a fungal infection, if they're immunocompromised, and they may be more at risk for some of these more kind of odd sort of bugs you might be running into, then at that point you may consider culturing. But for the most part, run-of-the-mill eye infections, you're just going to treat them empirically and kind of go from there. So again, when you see someone with conjunctivitis, again, things that make you think, or the differential should include things like viruses, certainly environmental allergies, contact lenses are a big one. Anyone know organism you really think about when you think contact lenses? Fantastic, right? Everyone. For once, they spoke in unison. Amazing. Absolutely, that's really important because we've talked about antibiotics that cover Pseudomonas, and that's going to be important here as well, right? So it's one of those kind of board-style questions. Like you hear someone with a contact lens and an infection, you got to think Pseudomonas, right? Magical. Anywho, but again, less commonly, you can see some other more kind of systemic issues here, right? So some other causes for this conjunctivitis. You can have immune-mediated reactions, right? There's some autoimmune conditions that cause sort of chronic dry eye. You can see tumors that can have issues here. And when you're looking at the typical bacterial spectrum that could be causing infection, again, you're going to find a lot of typical sort of either skin flora or typical upper respiratory tract sort of bugs here, right? So things like strep pneumo, H. influenza, things like Staph aureus potentially, Moraxella catarrhalis. We've covered these already, right, when we talked about the ENT bugs, right? We talked about like AOM and sinusitis. We did talk about that, right? You guys watched that, right? I'm assuming everyone did, because it'll be on your test on Monday, so you should know that. Anywho, the main point, though, is we would like to eradicate this infection, right, and hopefully prevent any sort of long-term complications from occurring there, okay? So what are some antibiotics we're going to use here? Things to note here. I don't want you to memorize all the formulations, and you don't need to memorize every single indication for use. I'm just listing these out here just for your reference, right? You can kind of come back and look at these. Now, most of these you've already seen before, right? So you already know a lot of things about these drugs, in particular things like their mechanism of action. We know things like which ones might cover Pseudomonas potentially, right? So which off this list do you think would cover Pseudomonas? Cipro, certainly ciprofloxacin could. What else? Right, so anything with afloxacin most likely could do it, right? Because we talked about what class of drugs is that? Fluoroquinolones, right? So again, you already know a lot about these drugs because you've seen it used in other cases, right? So this is good. Things like gentamicin, right? What kind of antibiotic is that? Aminoglycoside, right? Does that cover Pseudomonas? It does too, right? You should know that as well, right? So anyways, we'll talk about these more specifically as we get into them. But again, these are sort of that categorizations I want you to make. If you look at a drug, fit it into that category, say, okay, gentamicin, I know that's an aminoglycoside. What do I know about that drug, right? How does it work? Blocks protein synthesis, right? Right, the aminoglycosides versus something like a fluoroquinolone. How does that work? No. Works on the topoisomerase on the DNA, right? It helps to prevent the DNA from actually unwinding so it can undergo things like transcription, right? It causes more of the strand breaks to occur there. Because again, if I know a fluoroquinolone, how that works, guess what? I know how moxifloxacin works, I know how ofloxacin, ciprofloxacin, I know how all those drugs work based off the fact that I can categorize it as a fluoroquinolone, okay? These are the associations you need to be making when you're thinking about these sort of drugs here, right? So if a patient comes in and they have some fluoxacin drug you've never heard of before, you can at least identify and say, oh, it's a fluoroquinolone. At least know something about that, right? At least identify some bits of knowledge about it. So anyway, oops, wrong direction. So let's start talking about the individual classes you're going to find here. So the macrolides, right? What fits into the macrolide category? So azithromycin, clarithromycin, and erythromycin, right? So those are the three main ones you're going to see here. Azithro and erythro are going to be the two main ophthalmic products there. Clarithromycin doesn't really have an ophthalmic preparation available to us. And so you're going to find here, these are very standard sort of run-of-the-mill ophthalmic sort of antibiotics. How do they work? It's on the slide. Block protein synthesis, right? So they're blocking those ribosomes from actually working, producing new proteins. So they bacteriostatic or cidal, you think? Bacteriostatic, right? Remember, stopping the protein production doesn't immediately kill off the bacteria. Good, so bacteriostatic. But again, they eventually will lead to cell death over time because, again, the bacteria are not going to be able to produce those new proteins. Eventually, it'll trigger off that apoptosis reaction there. The big thing you're going to find with most of these drugs is very common side effects are going to be eye irritation and hypersensitivity, right? Anyone could potentially have a reaction to this. Even though they're formulated for the eye, some people just have a bad reaction to anything kind of getting into the eye there. So that's always going to be kind of a common thing. Just like for any antibiotic, what's a common side effect for any antibiotic you run into? Or really any oral medication? Nausea, vomiting, diarrhea, right? So you can say that about any drug, right? You already know the side effects of almost any drug that's out there. Because when they do the clinical trials and they actually list all the adverse effects that happen in the clinical trials, at least one person had nausea, at least one person had vomiting, at least one person had diarrhea during that study. So they categorize that all the side effects that you can see there, right? Anywho. So again, we noticed, what are the big interactions you had to worry about with systemic macrolides? Big drug interactions. Is there anything that this interfered with? CYP3A4, right? Remember, CYP3A4 was largely affected by the macrolide, right? Remember, it was erythromycin was probably the biggest offender there. Now, why don't we have to really worry about this when you're using it ophthalmically? It's not a ton of it gets absorbed systemically, right? Most of us working in the eye, we don't have to worry about really causing systemic inhibition of CYP3A4. So the route really matters here. So if I had a patient who came in, and I said on a test question, a patient who had ophthalmic azithromycin being administered, would you worry about CYP3A4 inhibition? And that would not be a concern of yours, right? That might be a good distractor on a question or something, right? So looking at this, you can see that depending on the dosage form, the dosing may change a little bit. So for instance, if you're dealing with a solution or a suspension, typically the dosing is in what? Drops, right? So if it's a solution or suspension, if it's in a liquid formulation, then it's going to be in drops, okay? So typically the drops have been coordinated or have been calibrated based on the bottle, so it's administering a pretty set amount of drug there. So as an example here, azithromycin is still 1 drop into the affected eye twice daily for 2 days, and then 1 drop daily for 5 days, right? That's an example sort of dosing strategy there. Now, am I going to ask you specifically on dosing? No, right? But again, things you want to consider though. Remember with azithromycin, even though it's a, say for instance, like a time-dependent antibiotic, like you don't have to give it that frequently because it's a nice long half-life. So this is a benefit here to a patient. You only have to do this twice daily for an eye drop. That's actually pretty good in terms of administration and not having to do it too often. Erythromycin though, what do you notice here? Dosing inches or centimeters, right? You probably should be getting away from inches anyway, right? Talking about in centimeters. And so in these cases here, because it is a ointment, That way you're going to be able to dose it more in distance, right? So an actual length of the actual amount of ointment you're instilling there. So that's typically how you would dose that, because again, it's a little bit more of a solid dosage form, not quite solid, but you know you're getting that idea there. Notice here, you're giving it 2 to 6 times per day, depending on the severity of infection. And giving it every 4 hours is really tough from a compliance standpoint. Even though you say, we'll do it 6 times a day, the patient might not always be compliant with that, right? And so that can be a problem actually getting rid of that infection, okay? So again, if you see inches, just know it's probably either an ointment, most likely an ointment. If it's going to be in drops, it's probably a solution or a suspension, okay? What's the difference between a solution and a suspension? You have to shake a suspension. Why? It'll settle out of solution, right? It's not a nice homogeneous mixture. You have to, because the particles are big enough, they're going to settle out. So suspensions, you always have to shake. Solutions, not so much, okay? Okay, so again, oftentimes you're going to find that most people will have erythromycin eye ointment prescribed anyway, because these patients are coming in, even if it's a viral eye infection, it's still pretty raw, it's pretty irritated, patients feel very uncomfortable. Sometimes we'll just give this out anyway, just to help soothe the inflamed eye, right? We could certainly use other like Vaseline kind of products or other types of eye products we'll talk about a little bit later on, but this does have a nice soothing effect on the eye. Now, the only reason why we may use this and not really have to worry about resistance is why? Because it's such a high concentration, you don't really worry about bacteria really becoming resistant to erythromycin eye ointment. Now, again, if I were to say systemically, if you had a patient who you thought had a viral upper respiratory tract infection, would you either give them antibiotics just to feel better? You would never do it. This is kind of one of those rare instances where it's probably fine, right? And the off chance it is bacterial, it's probably fine just to use that there, okay? Now, azithromycin is considerably much more expensive. Erythromycin's been around forever. We use it a lot when, like you say, babies are first born. We'll actually put that in their eyes. Why do we put eye ointment into a baby's eyes when they're first born? Not necessarily. It's just if a baby's born vaginally, guess what? They're picking up all kinds of stuff from the birth canal anyway. So oftentimes we'll put that in their eyes. Actually, my first kid, I was just like, why do their eyes look so weird? Actually, I forgot they had put erythromycin eye ointment on there, just in case there's any bacteria in the birth canal that the kid might have picked up, right? So if you ever see a kid with really goopy eyes when they're first born, that's probably what it is. And of course, if it's your kid, you're not really in the right state of mind to think clinically, and so you're just like, oh my gosh. Kids look really weird when they're first born, so anything normal. Anyway, yeah, so azithromycin is used less frequently because it is much more expensive. However, it is nice from a compliance standpoint. So if you had a patient who you were worried about being compliant, they really needed it, you can use this twice daily as opposed to 4+ times a day. So again, you'll see it used occasionally, but not as often as erythromycin ointment. Okay, up next we have trimethoprim and polymyxin B. Now this is, again, we've seen trimethoprim before. What was it kind of combined with then? So sulfamethoxazole, right? And that combination is called what? Bactrim or Septra or whatever brand name you might run into. This is where you're mixing trimethoprim with polymyxin B. And if you remember polymyxin B, how does that work? It actually disrupts the cell wall, so it's going to be another kind of cell wall active sort of agent there. We have that, and then the trimethoprim, how did that work? Yeah, it works as a folic acid antagonist, right? So it's actually blocking production of new nucleotides in the bacteria by blocking the utilization of folic acid. So again, using a dual mechanism and to get a little bit better synergy there. So this is called polytrim when you're mixing these two here together. And so basically, again, you're going to get very similar activity as the macrolides, but just working through a different mechanism. Okay. Notice here it's still 1 drop, so you know it's either going to be an ointment or a solution or suspension there. And notice here every 3 hours. A lot of times a day, right? So again, obviously you're not having them wake up necessarily, but again, it's very frequent throughout the day. Again, for 7 to 10 days, very tough from a compliance sort of standpoint there, okay? Some people may recommend a little less frequently, but again, it just depends on the staying time and how well it keeps around. So again, if you have a patient you're telling, make sure you block off the puncture, make sure you're trying to keep that drug around for as long as possible. Sometimes that can extend the duration. You may give it a little less frequently there, right? Again, we'll be given for any type of bacterial conjunctivitis. Again, irritation is going to be the biggest thing. Not a lot of issues seen systemically, right? No real big drug interactions to worry about, nothing like that. What was the big problem with polymyxin we saw systemically? Well, you can see that more with like an or the otic preparation. Certainly you can see that for sure. But systemically, what do we see some issues with? They're really nasty systemically because the polymyxins cause a lot of like neurotoxicity, nephrotoxicity, ototoxicity. They're really nasty drugs here. But again, ophthalmically, you limit a lot of those systemic sort of side effects you see with that. Okay. You had a question, Cam?
Yeah. So is the reason you're showing us this because just to have an alternative to the previous ones?
Right. Depending on what's available, depending on if the patient has maybe an allergy, perhaps they've tried Azithro before and it didn't really work out too well for them. Maybe they had an allergy to that. This is a good alternative, right? Sometimes one may be cheaper than the other. Like erythromycin, polytrim, these are pretty cheap for the most part. Perhaps you're looking for something in an ointment formulation, right? Sometimes with like little kids, ointment's nice because even if you just get in the eyelashes, you can still get some contact there, even if it's really difficult to administer that. With a drop, maybe it's a little bit better for patients who are able to administer it themselves, right? So it's hard to say.
How much of a difference does it make doing like half an inch to an inch for the ointment when you put it in the eye?
What do you think? 50% difference?
Depends which way you go, right?
It's hard to say, right? So it depends on how much actual contact you're getting. Maybe an inch is overkill. Maybe you're getting too much. As long as you're getting good contact with the actual sclera itself, you're probably going to be fine from that standpoint, right? So again, if it's a little kid, maybe go more like a half an inch. If it's an adult, maybe an inch might be fine. Eyes don't really range that much in size, right? So maybe if you had like an anime character, you'd want to use like 2 inches because they have really big eyes. Just kidding. So just as an example, right? So kind of on a patient by patient basis there, again, most of the time it's hard to even get an exact amount anyway, in terms of like half inch versus an inch, and your patients are the ones administering it, so they might even get it wrong. So probably bigger patients maybe go for an inch, smaller patients half an inch, probably doesn't really make that big of a difference, right? Just getting it on there and getting contact with the eye is the biggest thing, right? Okay, next we have sulfacetamide, and again, this is actually working the same pathway that Trimethoprim did, but this is just working a little bit higher up on that chain there. So same mechanism essentially of blocking the nucleotide synthesis, just working on a different piece of that puzzle there. And again, this one usually comes as an ointment or a solution. You can see here, who might this be a problem for? What type of patient? Maybe like any allergies? Yeah, right, so it's a sulfonamide allergy. Now, we'll talk about allergies a little bit later. Patients say they have a sulfa allergy. That can be a really tough one, just like when someone said they have a penicillin allergy. It can be kind of a difficult situation clinically. Here, oftentimes what they're responding to is the sulfonamide drug, right? So sulfonamides like sulfacetamide, sulfamethoxazole, they certainly have a lot of cross-reactivity. Just because something has a sulfur in it does not mean they're going to have a cross-reactivity with that. So there's a lot of drugs that will say you can't give it if they have a sulfa allergy. It's probably not really that clinically relevant. They're probably unlikely to have a reaction, but this is one of those things you'll see a lot of going forward. But certainly, if I had a patient who maybe had Bactrim before and they had a bad reaction to it and an anaphylactic allergy, I probably would not want to give them sulfacetamide because I could see a local reaction right there. Probably won't have a full anaphylaxis, but they could certainly see some local eye irritation, right? So those would be things I want to watch out for. Next we have Bacitracin. Now normally when you see Bacitracin, oh yes ma'am.
Sorry, so if this solution is being you use it 1 to 2 drops every 2 to 3 hours, do they bulk up at night every 2 hours too?
Yeah, so that would probably be more dependent on the severity of infection. If they're usually at home, I'm probably not going to require them to wake up in the middle of the night to apply that. So you could say on your prescription, you could actually write that on there and say every 2 to 3 hours while awake. That way the patient is a little bit more clear on when to use it, right? Because some people will see that and they're like, I got to wake up every 2 hours, right? And then you're like on like an infant schedule, and that's no fun for anyone, right? You have bad night's sleep, and then you can be blear-eyed anyway, you can get in a car wreck, you don't want to do that. So you can always say while awake, and that's totally appropriate. Anyway, Bacitracin, where do you normally see this being used?
Yes.
Usually Bacitracin, right? Anyone ever seen that? Anyone ever get a cut, a scrape? Ever? We use this topically all the time, right? It's a very good antibiotic agent. We don't really use this systemically because it's actually really nasty from a systemic standpoint, causes a ton of organ toxicity. However, when used topically, it's a great drug, right? It's a very broad spectrum. This actually works by inhibiting some of the mucopeptides in a cell wall. So it's, again, another cell wall active drug here. Again, you'll see this either being used topically, which we'll talk a little bit about in the derm section later on. But here you can see Bacitracin ointment used occasionally for the eye itself. Again, it's an ointment, so you know you're going to be dosing it in terms of length. Nothing really special to note here. Again, and again, notice that any of these antibiotics, really the biggest side effects have been what so far? Eye irritation, right? The biggest thing you have to worry about is really like a sulfa allergy if you're using sulfacetamide. So again, pretty safe for the most part, really. And we'll talk about administration a little bit later. That's usually going to be the biggest thing to think about. Now, fluoroquinolones, this will be a little bit different. This is going to be something you're going to reserve for patients who you're thinking might have a Pseudomonal infection, right? So again, we have a couple of different drugs that are going to fit into this category here. We have things like ciprofloxacin, ofloxacin, right? Ofloxacin is going to be structurally related to which one? Levofloxacin, right? Levofloxacin is just that left-sided enantiomer there. We also have moxifloxacin and gadifloxacin, okay? Again, they're all working the same way to inhibit that topoisomerase, right? So they're preventing that unwinding of the DNA, and so that leads to strand breaks there. And again, we like to hold off on these because there's actually a little bit more side effects you can actually see with this. Again, a little bit more ocular irritation. Sometimes you can actually get this white precipitate that forms out with the ciprofloxacin. A lot of times as the drug, or the liquid kind of evaporates off, so sometimes you can have that white precipitate left over. Not clinically too important, but the patients might be kind of concerned about that. And then why do you think you'd see an unpleasant taste after installation? Right, think about the nasolacrimal drainage. Guess where it's going to go out eventually, right into the back of the throat, so they get that unpleasant taste. So you can see that with a lot of different ocular products, as we'll see here. Now again, drug interactions wise, what do we worry about drug interactions wise when giving fluoroquinolones systemically? Here you want specific. So yeah, I do want to watch out for renal elimination, certainly for those, but drug interaction wise, again, there was some CYP inhibition we did see with that. So again, look that back up. Like 1A2 is another one that the fluoroquinolones kind of hit pretty frequently. Right, so again, not too worried about that when we're just applying this ophthalmically, but I'm trying to make mention of this because again, you're going to see it on the test. I'm trying to start to make those little neural connections, right, facilitate those connections for you guys so that way it comes to your mind when you see a test question on it. Anywho, now that's going to be a particular test question, I have no idea. I did write your test though. It's a banger. It's going to be great. It's about 50% antibiotics, the first section. It's 25% ENT, 25% ophthalmology. Just FYI. Focus your studying accordingly. However, think about this though. Antibiotics show up in both ENT and in ophthalmology. So again, that stuff does carry over, right? Think about that. Anywho. So again, the fluoroquinolones, again, very effective when they use it, but we like to hold back on their use if we don't need to, right? So again, it's kind of like using too broad of a spectrum antibiotic if you just have a typical conjunctivitis. However, if you're suspecting Pseudomonas, especially when you're thinking of a patient who has like a corneal ulcer, or if they have a history of using a contact lens or something like that, that's when we're going to be busting out the fluoroquinolones for these patients here. Now, they're very expensive for the most part, much more expensive than your run-of-the-mill erythromycin or bacitracin or something like that, and we are actually starting to see resistance. So even though we do get really high concentrations, even things like Pseudomonas are starting to get more resistant to these fluoroquinolones. So really hold back on using these unless you have a really compelling indication to do so. Okay. Typically, these are going to give a little bit more frequently on the first couple of days or so to really kind of get the concentrations high up there, start to kill those bacteria, and then you can kind of back off the frequency in the preceding days or the days afterwards. Okay. But again, once you have conjunctivitis and contact lens wear, that's when you can really kind of bust out the fluoroquinolones. It's going to be kind of the most typical time we're going to use it there. Okay, next we have our aminoglycosides. The main ones you're going to see here are going to be gentamicin and tobramycin. Gent is probably going to be the more frequent one you see used clinically here. Remember, these, while they're working on protein synthesis, they do have bactericidal actions, right? So that was one of those kind of notable exceptions we talked about in the antibiotic section earlier. This is one where you, again, don't want to use these too commonly, mainly because you can't see corneal ulceration if used for even like, say like a week's worth of time. So again, these are going to be for more resistant infections. Maybe your Cipro is not working, and you can use this as perhaps as a backup, right? So again, corneal ulceration, not something you want to cause in your patient, especially if they already have one from particularly that Pseudomonas there, okay? Okay, and again, this is kind of just a reference back to talking about your different antibiotics and how they're working there. So again, just for reference. Okay, so remember when we're using our ocular antivirals, so now we're kind of switching over. So again, we don't treat a lot of the viral eye infections very frequently, but certain viruses we do like to treat, right? And we covered some of the antivirals in the ENT section, correct? We talked about things like acyclovir and valacyclovir. What's the difference between those two? Which one's the prodrug? Valacyclovir is a prodrug of acyclovir, right? What is the benefit of using that? Better bioavailability, right, is like 77% for valacyclovir versus like, say 15 or something, whatever it was for acyclovir, right? Again, this is why you're not going to see a lot of those prodrugs using the eye necessarily, because we're getting really high concentrations. The bioavailability is not an issue there. So we'll see a couple of these being used. And again, if you have a patient with a really severe viral infection, especially those immunocompromised patients, this is frequently where we're going to be using a lot more of systemic antiviral products as well. So if I have someone who has like a really severe like cytomegalovirus, like perhaps I'm giving like systemic antiviral medications potentially, depending on the clinical situation there. But again, most of the viral conjunctivitis you're going to see is like adenoviruses and kind of run-of-the-mill stuff like that. And again, we're not really going to be treating those with antiviral agents for the most part, right? Usually just supportive care. If you want to give them some eye ointment, if you're really going to help them through that, some artificial tears, whatever the case may be. Really symptomatic relief is the biggest thing you're focusing on there. However, there's a couple of specific ocular antiviral agents we'll talk about here. Most of the time, though, you're going to find that with really systemic or more severe viral eye infections, you're actually going to be using more systemic therapy anyway, right? So you can see someone who's having an viral eye infection, very severe, more invasive, and immunocompromised patient, maybe getting valacyclovir for that. But again, we're going to focus mainly on the ones that can be applied ophthalmically because we're in the ophthalmology section. So these are the two mains we'll talk about in terms of antivirals, okay? So this first one is trifluridine, or Veer-Optic. And so this one is actually working to inhibit viral synthesis by inhibiting that thymidylate synthetase. So kind of similar to what we were seeing with the other antiviral agents. Remember how those worked? Yes, most of them were getting incorporated into the viral DNA, but then they didn't have that sugar moiety on there, that sugar backbone, right? And so what happens then? Yeah, it stops any kind of elongation of the chain. We call those chain terminators because you can't produce any, or you can't put any more nucleotides on there. So because of that, the virus cannot produce new DNA, and thus the virus dies off, right? This is working by inhibiting that thymidylate synthetase, so that way you can't actually, it'll actually sub in for thymidine, and when it does that, again, it works as a chain terminator, okay? Now, other ones we saw like ganciclovir and things like that, those are going to be more guanosine sort of mimics. Here we're seeing that this is going to be subbing in for thymidine. Not so important for our testing purposes, but just know it works by blocking DNA synthesis in the virus, right? What's interesting here, though, is you can actually see a punctate keratopathy. So this is one of those cases where the drug actually can deposit in the eye itself, and so it could be something of concern for the patient. You could actually see this with a Woods lamp if you're doing a fluorescein stain for your patient. We'll talk about fluorescein a little bit later on. Again, ganciclovir is another common one. We'll see this for like cytomegalovirus, and so this is actually usually comes as like an ocular insert. And we talked about the mechanism here, how it's going to be inhibiting incorporation of guanosine into that DNA, and it works as that chain terminator again here. Again, you can see ocular irritation, you can see keratitis from this. Again, those are kind of the more common things. Eye irritations is the biggest thing to worry about. Again, here's an example of what the insert would look like. This is actually a tablet of the ganciclovir itself, and then it would actually be implanted into the eye itself. So it'll intravitreal sort of implant, and that will slowly release drug at very high concentrations, and can helpfully get rid of that CMV. Okay, there's a few ocular antifungals we'll use here as well. And again, if you have a patient with a severe fungal infection in the eye, they probably have some degree of immunocompromisation, and they probably are going to need more systemic sort of therapy. And we talked about a few antifungals before, right? We talked about like the azole antifungals. We talked about things like, amphotericin B, right? Made a really funny joke about being a fun guy. Anyone remember that one? Good times, right? Anyway. That's when I really had to step back and kind of look at myself, and I was like, why am I talking to myself in my office, laughing at my own jokes? Like, bit of a midlife crisis kind of there in that moment. But anywho. So again, who are the patients who may be at risk for fungal ophthalmic infections? Typically, it's going to be things like trauma. If you have people with contact lens wearers, this could also be under differential as well. And again, especially with immunosuppression. This is particularly if you have someone who's receiving topical steroids. We'll talk about those a little bit later, but that can cause a local sort of immunosuppression, and fungus could potentially cause an infection at that point. Now, natamycin is really the only one we're going to see being used topically in the eye. Most of the other ones are going to be typically either compounded specifically for that. So this one is commercially available, meaning a company actually produces this. These other ones would have to either be made by a compounding pharmacy, which typically is more expensive, more specialized, or it has to be given, say, potentially intravenously. And again, we know there's some risk associated with a lot of these antifungal agents as well. Right? What are some problems with like the azole antifungals in terms of their drug interactions when used systemically? Big CYP3A4 inhibitors, remember? Because how do they work in the fungus? They prevent fungal cytochrome P450 from actually producing the fungal cell wall, right? If you remember that. So again, they'll do the same thing to our CYP enzymes as well. So those are good things to know about these drugs here. Amphotericin B, remember we know that's really bad on the kidneys. We know there's a lot of problems there. But nanomycin is the only one we're going to see used topically that's available commercially. And again, basically working similar to some of the other antifungal agents we've seen there where by increasing that permeability in the cell membrane, it's going to, and by binding that sterol, basically increasing that permeability, you kill off that fungal cell there. Okay. Again, not important to remember every single fungus that this can treat. It's pretty broad spectrum, though, and so if you did have a fungal ophthalmic infection, this could be a good agent for that. So, whenever you're administering ophthalmic medications to these patients here, you always want to check a visual acuity both before and after because you kind of want to see where they're at baseline. So it could be diminished there, and then you want to make sure they're at least improving or not getting any worse, right? If they're getting worse, that's probably where you need to kind of step back and think, okay, well, do I need to refer out to ophthalmology? Do I need to send them to the ER? Whatever the case may be there. But certainly always consider roping in your specialist if need be. Okay, let me just finish this section here and I'll do a break. So how do you administer ophthalmic medications? What's the first step always? Wash your hands. Why? Because we have dirty hands, right? It's just natural. Hands are pretty dirty. So wash your hands thoroughly. Make sure you use soap and water, most important. And then make sure they avoid touching that dropper to anything. So those bottles, when they receive them, are going to be sterile, and they need to be kept sterile as best they can, right? So if you start to touch them directly to the eye, guess what they can pick up? Viruses, bacteria, etc. So you don't want to do that. So no direct contact with the eye. Also, it's probably going to not be too comfortable when they do that there. So typically what you tell them to do, you want to have gravity not working against you, so you have them tilt their head back, and then you pull the lower eyelid down to form a nice little pocket there, right? So you have the nice cul-de-sac available and instill the drug right into that, right? Next, you want to hold the dropper with the opposite hand, again, close as possible, but without touching, and you're going to squeeze one drop at a time there into that pocket, okay? Once you do that, then you're going to go ahead, have them tilt the head back forward, and they want to hold their hand over the lacrimal duct, and that way they prevent any sort of drug absorption if possible. It keeps the drug there for longer, but keeping the eye closed. And we like to hold it there for at least 2 to 3 minutes or so. That ensures you're getting pretty good contact time. Now, if I told you to apply an eye drop and I told you to sit there for 2 to 3 minutes, how long would it feel like? Like 10 years, probably, right? Yeah, exactly. Very long time. So we tell them 2 to 3 minutes. Hopefully, it'll at least be 30 seconds, hopefully. But that's what we tell them, right? And then any excess, you can then wash that away, right? Now, when we get into something like the glaucoma meds, we might see multiple eye drops or having to administer at the same time. You do want to give some time in between these to make sure one has time to absorb before you apply another drop and kind of wash that drug away in favor for another one, okay? Now, when you're looking at drops versus ointments tend to be better for kids because, again, they're going to be fighting you. So even if you get on their eyelashes, it'll still probably get some contact there, and you can get some drug to work, okay? Note there with your ointment, so it's going to blur your vision for at least 20 minutes or so. And so why might that be a problem? If you need to go drive somewhere, if you need to go do something where vision is important for you, you're probably not going to be able to do it, right? On the other hand, drops, solutions and suspension is not going to be as big of a deal there, okay? With gels and ointments, the process is still pretty similar, but you're going to squeeze that ribbon. And again, if you're applying it yourself, you're going to have a hard time figuring out if it's a ½ inch or an inch, whatever the case may be there. But try to get the medication into the pocket, and then at this point, you don't need to close the lacrimal duct. And why is that? Because it's more viscous, it's not likely to drain out the same way that a liquid would there. So that's kind of the big difference. You don't need to sit there and hold their finger. Okay, if a patient has a contact lens, what should they do if they have an ocular infection? Stop using them, right? Switch back over to glasses. Sorry if it makes you look bookish. It's okay. Some people think that's cool. I don't know. But make sure not to use your contact lenses, and at least wait till the eye's not inflamed. There's no discharge for at least 24 hours before you start to go back to that. Now, can you use the old contact lenses you're using before? No, that's grody. Don't do that. Throw them out. Get some new ones. Or at least make sure they're really well disinfected, right? So using some peroxide or something like that. And then unfortunately, they do recommend getting rid of any eye makeup. Why is that? Could be contaminated. And you're like, but that was that really good stuff from Sephora. I'm sorry, they recommend getting rid of it. However, people who keep using the same stuff and they don't realize, why do I keep getting this recurrent eye infection? That's weird. Could be the makeup, right? You never know. Anywho. Okay, any questions so far? No, let's do, yes, ma'am.
Artificial tears over the counter, like, does that still apply for the whole holding the tongue stick closed? Because I don't know if that action needs to be absorbed or if it's just replacing tears.
It's a great question. In fact, we'll talk about that as soon as we get back from break. So you gotta leave them with a cliffhanger. Yeah. Any questions for the first half? Ophthalmic stuff. Someone asked a question. They said, just to confirm, we need to memorize all doses that are on the PowerPoint slides. What do you think? Negative. Do not memorize every dose that's on there. However, so if I ask a test question and there's like dosing present, unless the question is specifically about like why do we dose it a very specific way, like why do we dose a time-dependent antibiotic 4 times a day, that's a conceptual question you should know, right? However, if I put a dosing on there, I say I put 4 drugs and 4 different doses on there, just assume those are correct. Like I'm not trying to trick you on what the actual dose is. That stuff is more for like Clin Pharm. When you're on rotations, you'll figure out the dose, right? I was explaining it to someone today, and it's not that I want you to memorize every single fact that's on every single slide, but I want you to know, like when you get out there and you're reviewing stuff, or a patient comes up with a complaint, whatever the case may be, I want you to at least know that, oh wait, I think this drug might be a really good option for that. I don't remember everything about that drug, but at least I know what to go look up, right? If you don't even know what to look up in the first place, then you're kind of out of luck, okay? So those are the things I want you to focus on, right? Kind of getting these big key concepts here, not getting bogged down in every single specific detail, okay? Make sense so far? Okay. Anywho, let's see. Do intravitreal subconjunctival injections have a concerning systemic effect, such as intravitreal ganciclovir? So usually within intravitreal subconjunctival drugs, depends on their intended duration of action, right? So for instance, when we had a surgical patient who was getting subconjunctival steroids, that was more of a short acting sort of medication. It's a one-time dose, is meant for that inflammation related to surgery. Not really going to see a ton of systemic effects from that because it's still fairly locally administered. However, if you had like intravitreal ganciclovir, because it's there for a long period of time on the course of say months potentially, then maybe you could see some issues there, right? Less likely than if you're getting the drug say intravenously, much bigger doses intravenously, but there is still a risk, right? So there is some bone marrow suppression that could potentially occur, but lower risk than if it was given systemically. That makes sense. Okay. Any other questions? Nothing at all. Let's continue on. Next, we're going to getting into talking about eye allergies. So we talked in the ENT section, we talked about histamine already, right? So we talked about antihistamines. This is going to come up again here. What were some problems with using some of our, say, for instance, like first generation antihistamines? Sedation. What else? Or new sedation, right? Benadryl causes you to get sleepy. What else can it cause? You can say maybe a little bit of that, but not a ton with the H1 blocker, right? H2 blockers kind of stop that for the most part, right? But what else do you see? Remember, a lot of them had anticholinergic properties, right? So what are the anticholinergic kind of mnemonic you would see? Antimuscarinic specifically. See mydriasis, you could see, what does it do to your GI tract? Slows it down, right? You can see constipation. What does it do, say, for instance, to your mucous membrane secretions? Decreases them, right? Remember, what's the mnemonic? Blind as a bat, mad as a hatter, dry as a bone, red as a beet, hot as a hare, hot as a match, whatever you want to use, hot as Hades, some people say, if you're a subscriber of Greek religions. Right, and then the heart runs alone, right? That's what they say as well. You get tachycardia from it. So there's some issues with using systemic H1 blockers, specifically the first generation agents. Remember, second generation, what was the benefit with those? They can't cross the blood-brain barrier. They have that permanent positive charge on there, so they lose a lot of that sedation effects. You lose some of the more systemic sort of antimuscarinic effects, which is beneficial. But again, here's a way we can actually administer local antihistamines, and we're going to see how that can be beneficial to help when you have eye allergies, right? Whether it's due to environmental causes, whether it's due to pet dander, whatever the case may be, whatever you're running into. And again, remember that the inflammatory cascade is exactly the same as what we saw in ENT, right? You're still having histamine being released, serotonin, leukotrienes, all kinds of things. Remember that arachidonic acid pathway? We do talk about that. Like ibuprofen, aspirin interact with that. Remember that enzyme is really important. The COX enzyme, right, cyclooxygenase, forms all those prostaglandins and whatnot. This will come up again, right, because we do have ocular NSAIDs and glucocorticoids and histamine blockers. So all of this stuff is still going to apply. It's just locally administered to the eye itself. And again, when we see the inflammatory cascade kicking off, this is where you get that vasodilation. You can get that swelling, redness, itching, all that fun stuff you experience. So anytime like I get around a cat, invariably my eyes start to water up, they get red, itchy, it's no fun, right? Again, why cats are bad. I'm just kidding. Dogs do the same thing, but they're great. But again, what's happening though is you're seeing these mast cells degranulate, right? The mast cells are opening up when they're being triggered off by one of these allergens, and so you can see all these different mediators, these inflammatory cytokines being released here, and that's why you see the capillaries start to open up. They get that swelling because you're losing more fluid out of them. That's why you get the redness. Those vessels are dilating. That's where you get all the itchiness and whatnot from the histamine and things like that, because you're stimulating these nerve endings there. Okay, so what we can do we can either block some of the inflammatory mediators, right? So we can do things like blocking the actions of histamine, which we've seen before, or what else could we do? Maybe higher up on the scale of things. Could you like maybe block the reaction from occurring? Yeah, you could actually use what we call mast cell stabilizer. So that's going to be another mechanism we're going to see here. If you prevent the mast cell from degranulating in the first place, maybe you can prevent the reaction from occurring, right? Now, would that be effective for someone who comes in and their eyes are already injected and they're tearing and they're itchy? No, because those mast cells have already degranulated, right? It's not going to be all that useful there. However, if maybe someone's using this prophylactically, or they know, hey, I'm going to be around animals, or I know seasonal allergy time is coming up, or if they know they're going to be exposed to something that triggers them off, then perhaps they can use it as a prophylactic, okay? So again, you can see some different ways we can try to manage these patients. So we do with an H1 receptor antagonist. Actually, interesting, not really an antagonist, more of an inverse agonist, which means they actually cause the opposite effect when they bind that histamine receptor. But they're still competitive with histamine, right? So they're still binding for the same sites there. They're just preventing histamine from kind of doing its thing. But by interacting with that, we're going to decrease the capillary dilation, decrease itching, swelling, all that good stuff, right? We covered all those other physiologic actions in the ENT sections. I'm not going to belabor those points here, but remember those more systemic side effects you get, especially with your first generation antihistamines, right? And again, what are some agents that fell into that category? What was that?
I never heard of
So remember, so you have your second generation, you have your first generation. So fexofenadine, which I think you're trying to get at, it's actually second generation, right? What are the other second generations? Cetirizine, loratadine, fexofenadine, okay? And then your first generations, there's a lot of them in that category. Diphenhydramine, right, which is Benadryl. Dimenhydrinate, which is Dramamine. Doxylamine, which is Unisom. What else? Even promethazine or phenergan sort of fits in that category. Anything else? Talk about scopolamine is an antimuscarinic. It's not really antihistamine, but it certainly is a pure antimuscarinic. But again, the benefit here is that we're not really getting a ton of those systemic side effects because we are applying them just locally here. So you'll find that a lot of these antihistamines actually have some mast cell stabilizing properties as well. We do have a few drugs that specifically do that, and we'll kind of touch on them. The key benefit here is that this will work already on mast cells that have already degranulated. So this will work on a patient who's having an acute allergic reaction, because it's working specifically to displace that histamine and prevent it from having its normal mechanisms here. The nice benefit, especially of something like ketotifen or Zatador, is it was one of the more recent ones that became available over the counter, which again is increasing the accessibility, getting more patients able to use it there. Right, most of these other ones are available prescription only, things like azelastine. Epinastine, olopatadine, things like that. Olopatadine is probably the more common one that I've seen used, but certainly the Zatador, since it became over the counter, gets a little bit more wider use there. So again, you're going to find the action being fairly quick, which is beneficial with those, because if a patient's having acute allergic reaction, they probably want to have acute treatment, right? However, for patients who are going to have more, say, like seasonal allergies, where it's going to be more on a long-term sort of scale of things, give it 2 weeks or so before you really can assess sort of full efficacy there, okay? In terms of side effects, though, some of them make sense, right? So why do you think you see increased ocular dryness? Dry as a bone, right? So again, they're having local effects, but you can see that local drying there, right? So that can, again, itself cause irritation. So again, that's kind of leading to why you see those normal sort of side effects along with that, okay? And again, no big significant drug interactions, and typically these are preferred over the mast cell stabilizers. Mast cell stabilizers are going to be better for patients who have more sort of long-term sort of needs for therapy, but you're using it more as a prophylactic, and if they cannot receive one of the antihistamines in the first place. Maybe they have a bad reaction, maybe the drying effect is too much, so instead they'll use something like a mast cell stabilizer, okay? But again, these are not going to work on patients who are already having their mast cells being degranulated, so you need to use this before they're exposed to whatever irritant that is causing the reaction. So things that fit in this category include cromolyn, lidoxamide, and then netocromol. Those are the three main ones you're going to run into in terms of mast cell stabilization. Again, these are going to be used less frequently typically than you would for a patient than they would receive antihistamine, for instance. Now these ones I mentioned, not good for acute symptoms, but you have to use it for around 5 to 14 days or so before you can really assess full efficacy. And this is better for patients who have failed antihistamines. They can move on to this and then try and see how they do with it. Okay. Oftentimes they require more frequent dosing than your antihistamine. So again, another negative side to it. And for instance, with an antihistamine, you could dose that potentially as an as-needed sort of medication, right? So if they have occasional symptoms, they can use it as needed. This one would always be a scheduled medication, right? Because again, you're using it as a prophylactic, so you need to make sure they're scheduled kind of around the clock for that. Okay. Okay, and again, pretty typical symptoms here you would expect to see with any ocular medication, nothing too spectacular. Okay, so instead, what if we wanted to deal with, say, particular symptoms, right? What if we wanted to deal with, say, we had eyes that were particularly teary, they were having a lot of injection going on, a lot of vasodilation here. How can we deal with that, right? Well, this is where we can actually use some vasoconstrictors locally in the eye in order to help deal with that. So if you're having a lot of redness in the eye, this can actually help quite a bit with this. Again, kind of classically, what do you think about like the kind of person who needs Visine, like kind of made for illicit substance use?
Yeah.
Marijuana, right? Because again, marijuana oftentimes will cause red eyes, right? So people try to use this to try to counteract that. So I always think about it as like the prototypical, like, I need some Visine, man. Got to go to work, man. But some people just have allergic symptoms, right? And so they want to deal with that red eye there, right? And help with some of the tearing, excessive tearing there. So this is where these can be beneficial. So we have tetrahydrozoline, we have nefazolin, and then phenyramine. This one's actually an antihistamine, and then they co-formulate it with nefazolin to get this Nafcon A. So most of these are available over the counter, which can be problematic, right? Because when things are available over the counter, what can patients do? They can use them themselves as much as they want or as little as they want with no interaction with you, the healthcare provider. So this is actually a really important counseling point for the agents here, is you really want to use these for short-term use, right? Less than 2 weeks, because of the way that these actual agents work, right? We saw something very similar to this in the ENT section. Anyone remember a similar drug? Oxymetazoline, right? What's the brand name for that? Afrin, right? What was the problem with using Afrin for too long? Rebound nasal stuffiness. Why did you see that? I knew it caused rebound nasal stuffiness. Isn't that enough? Isn't that enough? No, I want you to know a little bit more, right? Why do you see that? Well, remember, these drugs are working as vasoconstrictors. They're working by activating which receptors? Yeah, so they're actually alpha-2 agonists, which you tend to find that locally, even though they'll actually cause some alpha-1 activation as well, because again, you're getting kind of high local concentrations there. When you activate those receptors, what you're going to find is you cause vasoconstriction to occur. When you're chronically giving that, and you're chronically seeing that activation of alpha-1 receptors, what happens to them over time? Desensitization, do they upregulate or downregulate? They downregulate because you're getting overstimulated, right? So when you take that drug away, what happens? Now you have fewer alpha receptors to target, to activate, and so what happens to those vessels? They dilate, right? Because again, they don't have as much alpha activation, they don't have as much vasoconstrictive sort of influence, and once you take that away, they get that rebound effect because the vessels just dilate like crazy. The same thing happens with the eyes, right? You can see that rebound hyperemia that occurs there with prolonged use once you go cold turkey. So this is one of those things you have to make sure they're using it for less than 2 weeks, and if they do use it for more than 2 weeks, they need to taper off of it slowly in order to make sure they don't get that rebound effects there, because they can oftentimes be worse than whatever you're trying to treat initially. Okay, those are big things to think about there. Okay. So really good counseling point for those patients. Oftentimes, though, with over-the-counter medications, patients are also self-treating. What if they have something else going on, right? So what if they have a bacterial infection that they were trying to treat the symptoms of with one of these? That's why you tell them, hey, don't use it for more than 72 hours. If things are not getting any better, come on in and see us, right? Because we may need to prescribe something else like an antibiotic or something in order to help manage that, okay? That's the problem with self-treatment. Patients will self-treat themselves to quite a bit before they realize, oh, wait, maybe something else is going on here. I should probably get seen, okay? So this is why we like to counsel on these things, okay? And again, systemically, you can actually see these drugs are pretty similar to, there's going to be antihypertensive we'll talk about later called clonidine. I probably mentioned it once or twice. But this is one of those things where systemically, it can actually cause some pretty significant effects. It works as a sympatholytic. Anyone remember what that means? It like decreases sympathetic outflow through the rest of the body, right? So when you use it systemically for blood pressure effects, we actually use it to lower blood pressure, lower heart rate, because it actually blocks further release of norepinephrine. So it's kind of a counterintuitive thing. Locally, it causes vasoconstriction, but systemically, it can actually cause vasodilation. This is a really big problem because if a kid gets into this stuff, a kid gets into a bottle of Visine and swallows that can be a really significant ingestion, right? They get very severely bradycardic, hypotensive, and they might end up in the ICU. So that's a really big thing we worry about in terms of these over-the-counter medications, just having things available. Typically, you think it's over-the-counter. It's got to be safe, right? Right? Not necessarily. So that's the thing we have to always think about there. Okay, next we have our NSAIDs, which are also good. If you have patients who maybe are not responding well to antihistamines, or maybe they have some other cause for their inflammation, sometimes NSAIDs may be used. And this is a little more specialized. You may not be prescribing these yourselves unless you're working, say, in an ophthalmology office or something like that. But again, we have our non-steroidal anti-inflammatory drugs, the NSAIDs. Guess what? They work exactly the same as all the systemic NSAIDs we've already seen, right? What are those? Ibuprofen. What else? Now, is acetaminophen a COX inhibitor? No, it's not, remember? So even though we talked about it, because again, very frequently for self-care for ENT, a lot of patients are going to be taking Tylenol. They might be cycling Tylenol and ibuprofen, right? But it's not an NSAID. It's not an anti-inflammatory. You put Tylenol in your eye, it's not going to do much, okay? So we have ibuprofen, what else? Naproxen's the other big one we talked about. And then technically, what else fits in that category? Aspirin, okay? So again, we'll talk about other ones when we get into talking about pain specifically, but those are the kind of the most common ones you're going to run into, especially from an over-the-counter standpoint here, okay? These are doing the same things. Remember, by blocking cyclooxygenase, you prevent the production of things like prostaglandins and things like that. And we can use these locally to deal with that ocular irritation there. A couple ones you have available are going to include things like bromfenac, diclofenac, and some of these actually we'll see used systemically, so like ketorolac or ketorolac, however you want to say it. I think technically it's ketorolac, but you sound silly if you say that. So Toradol is typically the IV formulation, but here we have Ocular. Diclofenac is a common one you actually see used topically. So if you ever see Voltaren gel, you can see that used for topical preparation for the skin, in addition to formulations for the eye. So these are the ones we have available to us. This is used more commonly for, say, post-operative inflammation. So if they undergo ophthalmic surgery, we can give this to them in the immediate post-operative period. Because again, if you're cutting and dicing into the eye, guess what? There's going to be a lot of inflammation. This can help deal with that. And you may be able to use it for patients who have allergic conjunctivitis or maybe not doing well with the antihistamines or mast cell stabilizers. This could potentially be a backup, or if there's maybe in combination in some cases there. Okay, so not routinely recommended, but on a more specialized sort of basis. Okay, and again, adverse reactions you can see with this include things like irritation, obviously keratitis, increased intraocular pressure, which can be problematic for what kind of patients? Like a glaucoma, so that'd be one thing you want to be careful of there. And then next we have glucocorticoids. This is again another more even more so specialized sort of set of drugs here. We're not going to use routinely, sort of like in the family practice, urgent care sort of setting, but certainly you may find patients who are using these for more kind of chronic sort of inflammatory sort of issues with the eyes themselves. Now, if you remember, how do glucocorticoids work? It's a steroid, right? So how do steroids work? They work kind of at the top of the pyramid in terms of inflammation in these cases here. They work down in the nucleus to prevent transcription of a lot of those inflammatory cytokines. What were some glucocorticoids we talked about in ENT? So those are some of the mediators you're preventing from producing, like tumor necrosis factor and interleukin for sure. What are some of the agents that we saw that work as glucocorticoids? Prednisone, prednisolone, what else? Dexamethasone is another big one we saw there, right? So again, you're kind of familiar with how these drugs are working, right? Hydrocortisone is the other big one, right? That's basically cortisol, which your body produces anyway. You'll probably see a big spike of it right around Sunday night into Monday morning, right? A lot of cortisol. Yeah, no. It's funny, they say that that heart attacks are most common on Monday mornings, right? I don't know if it's correlated with my test being on Monday mornings or not, but that's what happens. They used to put my test at random times of the week, be on a Friday sometimes, and that didn't go so well because you kind of petered out in terms of energy if you have a Monday, Wednesday, Friday test schedule. That's why I moved them always to Monday, so you at least have the weekend to be kind of refreshed for it. So that's the background. That's why I'm never here for the test, because that's my professional day. Professional is kind of stretching it, but that's my day where I work somewhere else. And so, yeah, that's why I'm never here on those test days. But I'm here with you in spirit, at least. Anyway, back to it. So where do we use glucocorticoids? Typically for more severe ocular allergies here. Sometimes we'll use it for autoimmune conditions potentially, but again, very specialized sort of use here. The problem why we don't like to use this is some of the more chronic sort of effects you're going to see with these. These have a little bit more severe local sort of side effects. Again, by working from the side of the nucleus down, these are the most powerful sort of anti-inflammatories we have. Because if you're looking at, say, for instance, where histamine's working or antihistamines are working, they've after the mast cells are degranulated, they're only working on one particular sort of inflammatory mediator. If you look at NSAIDs, they work on a bunch of them, but they're kind of further up the chain here. Glucocorticoids are at the very top because they're preventing any of these mediators from ever being produced in the first place, right? So again, very powerful from that standpoint. And so generally these are better for refractory symptoms because of a lot of the side effects you're going to see with these. And we already saw systemically glucocorticoids cause a host of side effects, things like hyperglycemia, hypertension, hirsutism, all kinds of things. Locally, they can cause things like cataract formation. They can cause things like increased intraocular pressure, especially in people with like a history of glaucoma, right? That could maybe be the thing that tips them over the edge. Why do you think you see infection? They're immunosuppressive. So just like if you're giving someone systemic steroids chronically, you can see potential risk for infection. Same thing can happen in the eye. You can have delayed wound healing after surgery, and then you have corneal ulcers that can form there. So there's kind of a corneal thinning that can occur that can lead to an ulcer formation. So we'd really like to limit this to less than 2 weeks of therapy. Longer than that is where you start to see some more of these significant side effects. Now, what do we say about if we're using, say, long-term steroids, say oral steroids? What do you have to worry about in terms of duration of use? Right, you have to worry about adrenal insufficiency. Where do you run into that? What time frame? It's about a week, right? So if you're on have a patient who's on more than a week of systemic corticosteroids, you have to taper them off of it in order to make sure the adrenal glands kind of have time to kick back on and to produce its own cortisol. In this case here, do I have to worry about that, do you think? No, because you're not really seeing a lot of systemic effects from this. It's really more working locally, okay? Now, the agents that fit in this category, some of them we've already seen. So we've already seen dexamethasone and prednisolone. Some more of these have newer agents, and there's things like fluorometholone, loteprednol, and the rimelexone. These are actually going to be what we consider to be soft steroids. They're kind of like a second generation of glucocorticoids that we produce there. And the big benefits with these is that they have a lower risk for intraocular pressure increases. So due to their change in structure, we've made them such that if they have a history of glaucoma, if they have glaucoma themselves, this may be a reasonable steroid to use from those cases there. But again, very specialized, unlikely that you're going to be prescribing it for the most part, but you may see patients who are on them. Okay, so now moving into therapy for dry eyes. Now again, I'm dating myself. Has anyone ever seen these commercials? Anyone know that guy's name?
It was Bueller, right?
He was the Bueller guy, right? So Bueller. You probably think I sound like that frequently. Ben Stein. There used to be a TV show called Win Ben Stein's Money back on Comedy Central back in the day. Pretty good comedy show. Anywho, he's got a very particular voice, and that's why he's on a lot of those commercials. So we have the red, dry eyes, like that's kind of him, right? Anywho, so a lot of things can affect your ability to produce tears and to have that nice protective tear film there. So things like chemical burns, which I can run into quite frequently in terms of my practice in toxicology. I'll never forget we had this one case where and we were practicing in Duval County. Anyone familiar with Duval County, Jacksonville? Is it the
Pinnacle of Health.
Pinnacle of Health, sure, but in terms of culture, really advanced. I mean, very very multicultural sort of environment. I'm just kidding. It's like the Bible Belt kind of dipped down in there, and so the further west of Duval County you get more into kind of the boony kind of areas there. And so, of course, I was living out there during my time out there. Anywho. What we ended up seeing though is that little kids were out playing, and the only thing they had to play with at the time was a empty bottle of Drano. And as you do. And so they were tossing the bottle of Drano back and forth to one another until the lid came off, and then one of them got Drano in their eye, right? Anyone know Drano is a acid or a base? Sodium hydroxide is a very strong base, and so that can cause very significant corneal burns. And so we actually had to have that kid come in. And so what do you think you do with that? You wash it, you flush it as much as you can, right? Well, a little kid, it's hard to do that. They're fighting you. So I remember walking into the peds ER, and this kid was screaming bloody murder. He was just going crazy. We were trying to put in, have you guys heard of Morgan's lens? What is that? Anyone know what it is? Yeah, it's like a contact lens with a little plastic tube that comes off of it. You can hook it up to an IV bag of saline and just flush that eye continually. I might have a picture of it later, but it looks pretty creepy when you're using it. But you have to numb up the eye, usually with some tetracaine or something. You place the Morgan's lens, and you can just flush that. Well, imagine getting it to a kid with the ocular burn who's fighting you tooth and nail. Not easy, right? So anyways, the kid was screaming. I was talking to the doc, and all of a sudden he stopped screaming. I said, what the heck happened? Did he just like run off, or you die, or what happened? Turned back around, they'd given him ketamine, fortunately, and so that just like completely knocked him out. So he was off in like Disneyland, and while we were able to flush the eye out, and then everything turned out totally fine, right? So sometimes you got to do what you got to do. Point being, though, is that when you have these kind of burns, whether it be environmental, whether it be due to something else, you can see some pretty significant disruption of this tear film. And so even things like rheumatoid arthritis can cause this, vitamin A deficiencies, lots of things can lead to very severe ocular irritation. So what do we do? For one, if you can try to reverse whatever the cause for the dryness was in the first place, that would be fantastic, right? If it's due to an anticholinergic, we'll try to get rid of that substance, right? If it's due to burns, flush it out. If it's something chemical related, whatever the case may be. Some cases we'll actually do like those punctal plugs, the silicone plugs, sometimes cauterization. Just depends on the situation there, right? Now, what I'm going to mention here are mainly going to be the tear substitutes. Typically, these are either going to be hypo or isotonic solutions there, and they usually contain some sort of mixture of things like electrolytes, like salts and surfactants and thickeners. The main thing they're trying to do is to be able to stay in that cul-de-sac for longer than your normal tears would in order to help retain that time and keep the eye nice and lubricated. Now, again, depending on the situation, you may want to use something thicker like an ointment in some cases. It can be very beneficial. I see this most frequently, say, like in the intensive care units. Who do you think might be at risk for having, say, for instance, like dry eyes? Who do you think couldn't blink their eyes in an ICU? Why a vented patient? What do you think?
Because they are paralyzed.
They could be paralyzed. Yeah, so they're usually sedated very heavily in order to make sure they're breathing with the ventilator, right? So they're not fighting the ventilator. Sometimes they get paralyzed. So that way they have the better ventilator synchrony. Well, if you're paralyzed, you can't blink your eyes. So very frequently we have to make sure we're applying ocular tear replacements and things like that to make sure they don't have chronic dry eye, make sure they don't have corneal abrasions that can occur because of that. So that's a really important consideration, right? So again, you think eye drops, tear replacements is not a very important drug, but for those patients, it's super, super important because they can't tell you that their eyes hurt, right? Anywho, so a couple different varieties here. We have things like balanced salt solutions. It's usually like a liquid, that you just apply to the eye to kind of replace the tears there. You have more thick substances like carboxymethylcellulose and hydroxypropylcellulose, things like that, kind of longer molecules that stick around for a little bit longer, good replacements there. So these are all available agents, most of them over the counter, right? So very little danger for the patients applying it themselves. Biggest thing would be if they got it infected and they can see an infection after that, but very safe. One thing you could do potentially, though, is use an immunomodulator, okay? So what this does, you have a drug called cyclosporin or Restasis. Now, cyclosporin, oftentimes it gets used more for transplant, or patients with a solid organ transplant or like a bone marrow transplant. And so basically what this does, it actually helps to produce or helps to limit the production of something called interleukin-2. Interleukin-2 is a very potent inflammatory mediator that helps to stimulate T-cell activation. So for instance, if I have someone who transplants in, say, for instance, a liver, normally the body, does it like foreign proteins and materials? No, it wants to get rid of that, right? It's called graft versus host disease. What you can do is use an immunomodulator to try to prevent that inflammation from occurring. I could do the same thing in the eye if it's immune-related. And so what you end up finding is you have this increased tear production, that better vision, comfort, and all of that. However, it's much more expensive, and also you can see some issues here where it causes a lot of ocular burning and kind of foreign body sensation. So sometimes this actually prompts them to discontinue therapy because the irritation can be worse than what they're actually experiencing in the first place. So again, if you had a patient with that really chronic dry eye that normal substitutes were not working for, this might be something you could use as a backup. Okay, so any questions on that so far? I'm going to start to get into the glaucoma stuff. We'll see how far we get, and then we'll finish up on Friday before our review. What is glaucoma? It's increased intraocular pressure. Have you talked about this with Dr. Austin yet? I saw it. It's so funny because I can ask you, you guys have all had the same lectures presumably, correct? But yeah, you get varying answers on if you covered something or not. It's always so funny how that works. Anyway, so yes, we're seeing increased intraocular pressure. Now, why do we see this? What happens here? Canals of Schlemm. That's my favorite body part of all time, the canal of Schlemm, right? So there's a couple of things that could be happening, right? So it could be either that we're producing too much fluid, or we're not able to get rid of that fluid, essentially what it comes down to, okay? So we'll talk about different ways we can actually help them manage that. Now, there's certainly two varieties of glaucoma. You can have the closed angle versus open angle. Now, which one is more dangerous immediately? Closed angle, right? That's like a medical emergency, right? People can go blind from that pretty quickly. But the more chronic open angle glaucoma, that's what we're going to focus on, right? Usually the closed angle glaucoma is more of a surgical sort of issue. Open angle glaucoma is more of a medical issue. We can fix it with drugs over the long term, okay? Now we see there's two main ways we can treat this, and some of our drugs can do one or the other, or sometimes both in some rare cases here. But basically what we're going to see is by decreasing the aqueous humor production, right? Again, there's nothing funny about this. Anyway. Anyway. Or we can try to increase the outflow of that fluid through that trabecular meshwork, right? So that's kind of the two targets we can shoot for. Now again, if you're going to use multiple drugs, again, do you want to use two drugs that have the same mechanism? No, combinations oftentimes going to be your best thing. So you can use one drug that does one, another drug that does the other. That's going to be better synergism there, right? So normal intraocular pressure normally around 10 to 21 or so, but as we start to see higher and higher pressures, more pressure on the axonal nerve, you're going to see more damage over time, leading to that visual field loss. As I mentioned with the acute closure, that's where we're going to see an acute closure of that blockage of that outflow of fluid. That's where we're going to see really high pressures sort of immediately, versus when you have the open angle, which we're going to focus on, that's going to be more of a long-term sort of chronic issue the patients are going to have there. And again, just kind of showing you a pictorial example of the difference here. Here you're going to see that there's either too much fluid being produced or it cannot exit quickly enough. Here you have an actual physical impingement preventing any fluid from coming out. That's where you get those really high pressures, really kind of more of immediate sort of danger for the patient. Okay, so our goals here, hopefully we're going to help prevent this optic nerve sort of damage here over time and hopefully limit any kind of systemic effects. With these sets of drugs, you're going to see more systemic effects than we've really seen with any of the other things we've talked about so far. And again, this is where being able to close off that nasolacrimal drainage is going to be really, really important because there could be some pretty significant effects with some of these medications here. Okay, so here's how we break down our agents, and we'll cover these in a more particular example, but you should know, again, how they're working on the problem of this glaucoma, right, this intraocular pressure issue. To increase the aqueous outflow, we're going to have our prostaglandins. These are typically going to be your first-line agents here, okay? We'll talk about some examples that may not be the case, but typically first line for the most part. We're going to have our alpha adrenergic agonist. This is actually going to be kind of similar to the imidazoline derivatives that we saw with like your Visines and your Afrins. There's going to be similar class of drugs here. And they're cholinergic agonist. And then we're going to have drugs that work to decrease that aqueous humor production. So we're going to have things like your alpha adrenergic agonist. Notice here, this group does both. So it's kind of a unique sort of property there. Next, we're going to have our beta blockers. Beta blockers are a good kind of second line agent, sometimes first line depending on the patient. And then we'll also have a carbonic anhydrase inhibitor. We'll talk much more about carbonic anhydrase inhibitors when we get to the diuretic section, when we get into cardio later on. So again, oftentimes you're going to need multiple agents in order to help keep that intraocular pressure under control. Okay. So prostaglandins is the first thing we're talking to. Most of these are going to be analogs to PGF2. Normally, by the actions of prostaglandin, they actually help to decrease aqueous outflow by giving. They actually normally increase that. So by giving supplemental prostaglandins, you're going to increase the outflow of that the extra fluid. That humor is going to get out of the eye, and thus the pressure should decrease there, right? We're not really sure why that works. We just know that the prostaglandins tend to increase that outflow through that trabecular meshwork. We just know it works, so we're going to go with that, right? The agents we have to fit into this category, you're going to be able to tell them because they have prost at the end of the names. So you have things like latanoprost, travoprost, bimatoprost, and tafloprost. Think that makes sense? It says prost at the end. They're prostaglandin analogs, right? So that makes good sense there. Notice bimatoprost we're going to talk about in a second here due to one of its side effects, which we'll mention. Now, some of the adverse reactions you're going to note with these agents here are going to include things like the conjunctival hyperemia. So you can see a little bit of that vasodilation there. You can see with that. Ocular irritation, which is pretty normal for most ocular meds. And then also changes in eyelash length and the iris color. Anyone know what color turns your iris? Brown, right? So if you have brown eyes to begin with, is that a big deal? Not so much, right? If you have nice, pretty blue eyes, is that a big deal? Depends, right? If you're like 90 years old, you're like, I'm not worried about, trying to impress anyone. Maybe they don't care so much, right? But some people, that does make a big difference, right? So again, think about these sorts of things like eye color of your patient can actually dictate what drug you're going to use potentially, right? Something you don't really think about too frequently. Yes, sir?
Does it go back?
Typically, no. Especially with long-term use, right? Because it's going to be a chronic issue you're going to be treating for a long period of time. Typically, once it happens, it's not going to usually go back, right? For the most part. If it's like minor and you stop the medication, perhaps you could have some reversal, but you could see that it could be long-term, right? Right. That's one of the things. So when you think like your eye color, it's like part of your like identity. If you have brown eyes already, like, whatever, give it to me. It's no problem, right? Anywho, right. So you can see an example here. A patient probably had increased intraocular pressure in one particular eye. They're using a prostaglandin analog, you can see that darkening of the iris there, right? So again, had green eye in this one here, the right eye is much, much darker, okay? So it's quite noticeable there. Now for here, you also notice here that increased eyelash length. That was a side effect we noticed when we were using the actual product for glaucoma. You're like, man, look at this person. They have such long, luscious lashes now, right? We must be able to use this for our benefit, right? So this is where we can actually use Latisse here for the eyelash lengthening. Again, you can still see some of the iris darkening, so you do want to make sure you're counseling your patients on that. Yes, ma'am.
Latisse is technically prescription. I don't understand how, like the office I used to work at, they would sell it like over the counter, and you'd go there and buy it for like cosmetic purposes. How is that allowed?
I don't know. How was it allowed?
I don't know.
Maybe they're just
They like put stamps on prescription papers, and then if people want it, they'd fill it out.
there could be something like that. Maybe they're just illegal. Who could say? I would, this is recorded, so I wouldn't out them on here, but you never know. You should ask them though. You can always call them up and be like, hey, well, how do you guys get around that? It could be something you're just not. I mean, it could be something you're just not aware of. You never know. You never know. Or there could be dark dealings. Maybe you call them up and they say, don't call here ever again. Typically, though, you do need a prescription for this because, again, it does have some significant effects, right? Again, if you're handing out Latisse out of the back of your car and then your patient comes back and say, hey, you colored my eyes brown. They were nice baby blue before. That could be a problem, right? So these are things you want to consider for these medications here. Other big thing to know is it's nice from a compliance standpoint. These are only once daily, right? So they have pretty good staying power. Actually, when you give too much, though, if you were to say dose it more frequently, because you think, well, if some drug is good, more drug must be better, right? Not always, right? And this can actually blunt that intraocular pressure lowering effect and actually can raise it back up. So again, this is why we like one-time daily dosing for the prostaglandin. So again, good from a compliance standpoint. You can think about the eyelash thing, which is only a beneficial side effect for some people, I guess. Maybe if they got like really out of whack, maybe like cover your eyes, maybe impair your vision. I don't know. Never seen that, but the iris darkening is the big thing. Okay, now up next we have our beta blocking agents. How do these work? What do you think? Block beta adrenergic receptors, right? What normally activates beta adrenergic receptors? Epinephrine, norepinephrine, right? Those normal sorts of some pathomimetic sort of products, or those normal catecholamines. Normally what you see is when you have these beta blocking receptors here, normally when they get activated by something like epinephrine, you're going to see increases in the amount of cyclic AMP. You guys remember we talked about that many moons ago? The secondary messengers and all of that. Well, basically, when you block that and you decrease the cyclic AMP production, you see less aqueous humor production happen here. Okay, so we saw the prostaglandins increase the outflow of the aqueous humor. Here, we're actually decreasing the production of. So you can actually see a good combination of using a beta blocker plus a prostaglandin. You get very good synergy out of that because they're working through different mechanisms. Okay, now, what type of beta receptors do we have in the body? Beta 1 and beta 2. We also have beta 3, but clinically we don't see that come up too frequently. But beta 1, where do you normally find that? On the heart, right? Where do you find beta 2 frequently? On the lungs, right? You got one heart and two lungs, right? Anyway, so we'll talk about some beta blockers, and this will come up more importantly when we talk about systemic beta blockers used for things like blood pressure and arrhythmias and whatnot. We'll talk about it in terms of selectivity, right? Beta 1 selective agents versus non-selective agents. When I say beta 1 selective, they're going to primarily block just beta 1 receptors. If I say non-selective, they're going to work on either one equally, okay? Now, selectivity is all sort of relative, and in fact, you can overcome selectivity by increasing the dose quite significantly, but this will affect the kind of side effects you can see from these medications. You tend to find non-selective agents are going to be more efficacious here, but what do you think could happen, when you look at beta 1 receptor activation, what happens to the heart? Increased heart rate, contractility goes up. What happens if you stimulate beta 2 receptors, say, on the lungs? Bronchodilation typically happens, right? So what if I had a patient who had, say, a history of asthma or reactive airway disease, and I was using a non-selective beta blocker on that patient there? What could happen? Well, how do I fix their asthma attacks if they have one? Anyone know what we use? It's a typical asthma inhaler. Albuterol, right? It's a beta 2 agonist. I don't know if I've at least mentioned it once or twice there. It's a beta 2 agonist. Well, if I'm blocking those receptors, guess what? It may not work so well. So that's the thing. With you using a non-selective beta blocker in a patient with asthma or reactive airway disease, you run the risk of one, possibly inducing an asthma exacerbation for them, or maybe making their medications not work so well. So again, when you get asked the question, which one of these beta blockers is safe to use for a patient with reactive airway disease or asthma, Betaxolol would actually be a pretty good one because it's beta-1 selective and it's not going to interact so much with those beta-2 receptors. Does that make sense? Okay. So again, if you have that history, be careful using non-selective beta blockers. Not to say they're automatically going to die of an asthma attack, but it's just to say it could, one, make that drug work less effectively, or it could induce an exacerbation. The non-selective ones you see here are going to include cardiolol, timolol, and levobunolol. And again, why do we care about systemic effects when we're applying the drug topically? Remember that nasolacrimal drainage? This is where you start to see more of those systemic effects starting to pop up here when using a beta blocker. It gets absorbed through that nasolacrimal drainage, and that's where you can start to see some of those systemic effects. Meaning, you got to be careful on who you're going to use it on. So you got to be careful on a patient who has a history of asthma, the non-selective agents, that any of them could be a problem if you have a patient who says has heart block, or maybe they have congestive heart failure, right? And you're worried about their left ventricular function. If I block that beta-1 receptor, what's that going to do to their LV function? Going to go down, right? Because again, they need that beta-1 receptor activated in order to keep contractility up, to keep that blood flowing, right? Again, we'll cover that much more in detail when we get to talking about CHF and all that in the cardio section coming up. It's a lot of lectures we're going to cover, and it's going to get pretty in-depth on that stuff, so it's good. Okay, so again, know when to use a selective beta blocker versus not, especially in this case here. Okay, as mentioned, this is all the stuff we already talked about here. Non-selective agents are again going to affect both receptors. Beta-1 selective should only affect beta-1 receptors preferentially. Okay, up next we have our alpha-2 agonists, and again, these are working pretty similar to things like Afrin, to things like your Visines and whatnot. Again, these are working very directly, though, in the eye on topically, and basically what they're doing is they are working both presynaptically and postsynaptically, and this makes sense why they work on both outflow of the aqueous humor and also on production. Presynaptically, you're going to find it decreases catecholamine release, so you're decreasing release of things like epinephrine, and so then things like beta receptors don't get activated. So that makes sense, right? Because then it means there's less aqueous humor being produced there. And you also end up seeing a little bit of decrease in outflow. Postsynaptically, though, by activating alpha-2 receptors, that also will decrease aqueous humor production as well. So you can see how this works on both steps of the pathway, both on outflow and also on the actual production of the aqueous humor itself. Okay? Two drugs that fit into this category include aproclonidine and brimonidine. You're going to find that depending on the agent here, so for instance, brimonidine is more lipophilic. What do you think it does for maybe systemic absorption? Actually increases it to some degree, versus something like aproclonidine being highly ionized at physiologic pH. What do you think that does to absorption? Decreases it, right? It's highly ionized, so it's a harder time going across the membrane. So if you had a patient who may be at risk for having some of these systemic effects, aproclonidine might be a better option for them. And systemically, what would you end up seeing? Well, you'd see things like hypotension, bradycardia, right? Because it's decreasing sympathetic outflow. That makes sense. What do you think it does to overall CNS function? Decrease it, increase it? Decreases it, right? So again, you can see a lot of CNS depression associated with this as well if they did get significant absorption there. So again, that's why we don't use it in kids less than 2. They would have increased intraocular pressure because they see CNS depression, apnea can occur potentially. Again, as I mentioned, using something like aproclonidine is a little bit better to help limit that because it has less blood-brain barrier penetration, so it's less able to get up in the CNS to cause those systemic sort of effects. Okay, next we have our carbonic anhydrase inhibitors. Basically, this one gets a little complicated in how it works, but basically carbonic anhydrase is an enzyme that normally converts, anyone know what it converts? CO2 and water into bicarb, and then vice versa as well, right? You can turn bicarb into CO2 and water. Now, bicarb itself, does it like to cross membranes too easily? Doesn't really do it that well, okay? How about CO2 and water? That can cross pretty easily, right? So again, by blocking this conversion, you can potentially block bicarb on one side of a membrane or the other. So we can do this in the kidneys and actually increase the amount of urine being produced, so it works as a diuretic. Up top locally, we can actually use it in terms of the actual decreasing the amount of aqueous humor production here, right? So we can actually work to decrease that IOP because we have less fluid transport because we're blocking the passage of that water and that bicarb there, okay? There's 2 agents that fit into this category. We have dorzolamide and brenzolamide. The one we're going to talk about and use for as a diuretic is acetazolamide. We see zolamide that kind of clues you in that's a carbonic anhydrase inhibitor. These ones get used less frequently. Sometimes they're an add-on agent, mainly because of the side effects here. You see a lot of bitter taste, you see some of that stinging, and then more likely to cause some allergic conjunctivitis. So again, not use it as a first-line agent. Usually that's either your prostaglandins or your beta blockers. This is a good agent to add on, potentially if one of those is not working well enough. And again, it gets a little complicated, but basically the thing you're looking at here is that things like CO2 and water are able to cross over much more easily than something like bicarb can. Usually it's going to require some sort of transporters to do that, and so by blocking the activity of carbonic anhydrase, which you can see here at CA is that enzyme converting CO2 and water into bicarb, basically you're just preventing this outflow of the aqueous humor. So normally it would be flowing in this direction here. By blocking that, you have less aqueous humor being actually produced. Okay, so you don't get too bogged down in the details. Just know that it blocks carbonic anhydrase, prevents conversion of bicarb into that CO2 and water. Okay, so to wrap up with a few miscellaneous agents here, we have some cholinergic agonists. What do you think these are going to do in the eye? Picture kind of gives it away. Causes miosis, right? Causes pupillary constriction. So that actually is helpful to facilitate aqueous outflow in those cases there, right? So actually by contracting the ciliary muscles, you're going to cause the outflow to increase, right? So it's actual physical release of that pressure to allow that fluid to flow out there. What do you think would be kind of a common side effect to see with this besides miosis? Vision impairment, right? You're going to have a hard time being able to accommodate very well. So this is not going to be good for someone that needs to go out and say, drive a truck or go do things like that. So really poor compliance due to the frequent administration, just the side effects. Sometimes you'll see some of these being used directly though. So acetylcholine, well, that makes sense. It works as a cholinergic agonist because it's acetylcholine, right? It's what our body uses itself. We'll use this occasionally in surgical settings. Carbachol and pilocarpine are the other two that will do that as well. But again, you're going to see these fixed small pupils. You can see visual disturbances, headaches related to that. So again, not great. Better for patients who maybe already have pretty advanced vision degradation to begin with, or maybe they're failing other therapy potentially. And again, sometimes we'll have combinations of products we'll put together to get that synergy there. And again, by combining products, what's the benefit of that? Better compliance. Maybe more expensive though, right? So you may need to prescribe them separately in order to make sure that it's financially feasible for your patient. But the benefit of combining them is better compliance here, right? So if I can get, for instance, bromonidine and timolol, I'm getting alpha agonist plus a beta blocker, right? By using brinzolamide and bromonidine, what am I seeing here? Carbonic anhydrase inhibitor. Another alpha-2 agonist, right? So again, by combining these, getting intelligent combinations of mechanisms there, you get better synergy out of those just by themselves alone. Okay. So again, who to treat? Basically, those without risk factors. You have to wait until they start to have some kind of glaucomatous sort of changes occurring there. But if they have pretty significant risk factors, you just go ahead and treat those patients, even if their pressures look relatively, high sort of normal there. Typically, though, you either want to start with a prostaglandin analog or a beta blocker. If they have a history of asthma, which one would you go with? Probably prostaglandin, right? If they have, say, for instance, baby blue eyes, you might want to go with the beta blocker, right? So again, these are considerations you're going to be making here. Sometimes what you can actually do is try this therapy in one eye by itself to see how they tolerate it, and then if that works, then you can use it in both potentially. And the ideal goal is to try to get about a 20 to 30% drop in their IOP. Come back, see how they're doing. You can see how the compliance is working, see what their side effects are, and then you kind of change your therapy based on that. Okay, so I got no more time left, but we'll finish up this last little bit. I know I don't have too many slides left, but we'll do that, and then we'll go into the review next time we meet. Any questions before I let y'all go? Yes, ma'am.
When there is a combination drug like the Trimethoprim and everything like that, is it going to be referred to as that polytrim because it combines both words, or is that technically the brand name?
I will put the combination of the drugs. I'll put sulfacetamide. Trimethoprim polymyxin B / polymyxin B, and I'll put the polytrim in the parentheses there.
Okay, so that's technically the brand name is the polytrim.
Yeah, the polytrim would be the brand name for that. Any other questions? Nothing on the board. See, most of your eyes are already glazed over, so I will let you go, and then Professor Lack gets to come and wake you back up. Hey.